Hello everybody, thank you for coming to this speech this afternoon. My name is Kelly McKinnon and my thesis topic was computational modelling of radiotherapy and blockade immunotherapy towards synergistic therapy. So cancer occurs when cells uncontrollably divide and are able to escape the immune system. This immune escape occurs when the tumour co-opts key immune effectors and receptors exhibited on normal tissues that indicate self. This prevents immune response to the tumour as they are trained to not be autoreactive as part of their maturing response. The goal of immune checkpoint blockades or inhibitors, ICIs, is to negate tumour manipulation and allow the T cells to attack the tumour. A study on stage 3 and 4 metastatic melanoma found that the 2-year survival rates of patients increased from 24% to 46% after ICI treatment. The two most researched branches of immunotherapy concern the cytotoxic T lymphocyte-associated antigen 4, or CTLA-4 pathway, and the programmed cell death protein 1, or the PD-1 pathway. So the anti-CTLA-4 blockade causes an increase in the proliferation and diversity of effector T cells. It achieves this by bonding to ligands on the antigen-presenting dendritic cells that can be used by tumours to prevent immune recognition. The PD-1 pathway has two ligands, the PD-L1 and the PD-L2. Anti-PD-1 therapy acts on T cells, enhancing the activity of exhausted T cells that have been exposed to antigens for a prolonged period. Anti-PD-L1 blockade blocks the ligand that the tumour uses to trick the immune system into seeing self and does not affect the PD-L2 ligand. So the limitations of ICI come down to the autoimmune response that can result in an unpleasant side effect for the patient. And up to 90% of patients involved in one ICI study experienced immune-related adverse effects. Side effects can even be so severe that they result in death. This is a diagram of the most commonly reported side effects from ICIs as reported by clinicians. So now on to our next therapy, radiotherapy. It's an external beam radiotherapy that we're concerned with here, which involves the use of an X-ray beam to deliver energy to tumour cells to produce DNA damage and tumour cell death. RT is most commonly a localised treatment, meaning that you can only treat tumours that have been visualised. An X-ray beam radiotherapy deposits a dose distribution partially in healthy tissue, resulting in normal tissue toxicities, and that is a big limitation of radiotherapy. So cells that die post-radiotherapy undergo a violent death, releasing antigens that can stimulate an immune response. This immune effect is sometimes sufficient to upregulate the immune system attacks on the tumour, resulting in a phenomenon known as the abscopal effect, which is pictured here. This was actually the primary tumour in the breast, and these were the metastases. After a localised radiotherapy treatment just to the breast, this was the result. This woman experienced an excellent abscopal effect. But this effect is unreliable and irregular. So looking now at our immuno-RT combination treatment, once antigens are released post-irradiation-induced cell death, they can be presented to the now reactive immune cells to incite them to attack the tumour cells. This would turn the tumour into a vaccine within the body. Currently, we have a limited understanding of the optimal conditions for immuno-RT, and this can be explored through experimentation, but it is somewhat limited. The benefits of computational modelling are that we can explore concepts using previous studies and inform prospective studies, and then these experimental outcomes can be incorporated back into the model to further refine it. So the project aims were to identify current mathematical models describing immuno-RT and determine their most salient features for combining into a future model, and to identify the most sensitive parameters of the models and potential indicators of treatment success. So these are the materials and costs of the project. As you can see, quite a limited cost overall, with most of the materials required being softwares that were either free or heavily discounted for students. So looking at the ICI monotherapy models, the first step was to identify immuno-RT models. At the beginning of this master's, there was a single model, but partway through 2018, another one was published, effectively doubling the sample size, but it was deemed necessary to include ICI monotherapy models as well to increase the data to look at. So we had 3 primary and 1 supplementary model. The 3 primary models were by Kosinski et al., Serre et al., and Valentinuzzi et al. that concerned The first two were the immuno-RT models that looked at, in the case of Kosinski, anti-PD-L1 and RT. In the case of SARE, the PD-1 axis, anti-CTLA4 and radiotherapy. And in Valentinuzzi's case, it was a monotherapy model looking at anti-PD-1. We also included a supplementary model by Gong et al. Because it did provide some additional insight into the monotherapy, but it wasn't looking at the overall therapy efficacy, just individual variations. So models can be structured as either bottom up or top down, or a combination thereof. So, bottom up. Bottom up modelling aims to describe the measurements at the systemic level by working up from interactions at the molecular and cellular level. The goal is to identify the core actors whose interactions have the most effect on measurable outcomes. The Kosinski and Valentinuzzi models both make use of the bottom-up methodologies. Kosinski et al. Use a quantitative systems pharmacology or QSP model, which consists of a set of ordinary differential equations that describe the dynamic properties of drug interactions with a biological system. Valentinuzzi et al. Is a simpler deterministic model, which is built such that the parameter interactions have absolute determination on the outcomes of the system. So next, we have top-down modelling, which can be used to investigate systemic changes without the need for a rigorous mathematical understanding of the underlying mechanisms. This is in the case of the SARE model, which aims for a phenomenological description of immuno-RT interactions without requiring a detailed knowledge of the mechanics of the interactions. The type of model can be used as a general guide as to the evolution of biological phenomena, but they are not able to give a quantitative insight into biological systems. So then we can also have a combination of the two. Multi-scale models incorporate lower-level molecular and higher-level systemic factors, such as in the case of the Gong model. This means that the individual molecular and cellular interactions can be considered, but also how they interact with a heterogeneous complexity of TME architecture, or in the tumour microenvironment architecture. So the goal, because biology is governed by macro-micro as well as micro-micro interactions, such as in the case of tumour perfusion, vascularisation, which has an impact on ICI and RT treatment efficacy and other such actions, systemic factors such as tumour architecture are likely to be crucial to the efficacy of an immuno-RT interaction. As such, the optimal model should consider the multi-scale interactions when attempting to describe immuno-RT therapy factors. But this does introduce a high level of complexity, and so this could result in an overall reduction in predictive power of the model. An intermediate option would be to form a bottom-up model, and then it could be extended to create a multi-scale model in the future. So next, we need to look at tumour growth models, which form the basis of the therapy model. The exponential model is used by both the SARE and Gong models. Tumour cells in the early stage of growth do divide at regular intervals, making an exponential growth model representative over this initial period. However, doubling time does not remain constant through tumour development, and exponential growth parameters may be inaccurate as a result of poor assay techniques at this very small cellular level. This can result in a pronounced difference between experimental and modelled outcomes. Next is a logistic model, which is what the Kosinski model uses. A study that investigated the validity of tumour growth models found that logistic growth models were a very poor indicator of experimental outcomes. It and the exponential model exhibited inferior fits to experimental data in their study, so inferior in fact that both models were kicked out of the study partway through and not continued to be analysed. Lastly, we have the Gompertz Model, which is what Valentinuzzi uses. The Gompertz model is an asymmetric form of a logistic model, and it is considered one of the most experimentally representative tumour growth models. It describes a growth rate that decreases at a constant rate, giving rise to a sigmoidal curve. It is an accurate descriptor of cancer growth, reflecting the decrease in cancer growth rate seen in experimental circumstances, and it is popular as it is easy to fit to experimental data. But the parameters themselves are not rooted in biological phenomena, though that does not have an impact on a model such as ours looking at therapy outcomes. Therefore, though there is no consensus on the optimal tumour growth model, the Gompertz model is considered a good fit to experimental data and introduces only a few free parameters that can be easily experimentally determined. This research has determined that a Gompertz model would be an excellent starting point for an immuno-RT model. So next, consideration of the removal of dead tumour cells is important as part of the model. Serre and Gong models equate cellular death with its immediate removal from the TME, whereas Kosinski and Valentinuzzi model the removal rates of the cells themselves. So Kosinski et al. Consider the contribution of pre-apoptotic cells towards the tumour volume as a separate parameter to healthy tumour cells. The Valentinuzzi model simplifies this clearance rate to 4 cell doubling times. So tumour cells do continue to be part of the measured tumour bulk for a period afterwards, and in order to fit a model to experimental data, explicit modelling of the removal of tumour cells does have to be considered. It would be worthwhile to explore what Valentinuzzi does in terms of a multiple of tumour doubling times, because this may be an acceptable simplification for the data. Next, we have the effectors involved in the modelled tumour response. So all except for Serre do have specific immune effectors, and they all incorporate the interaction of tumour-infiltrating lymphocytes, or TILs. The Gong model considers non-differentiated effector T cells and their activation after interactions with tumour cell antigens. Kosinski also considers both differentiated and undifferentiated T cell forms, and has a constant value for the rate of effector T cells that differentiates into cytotoxic T cells. Valentinuzzi has the single TIL parameter that has been assigned as the cytotoxic killer cell. The Kosinski model also considers mature dendritic cells and their effectiveness in the role of antigen presentation, particularly after irradiation. The Valentinuzzi model considers MHC, or major histocompatibility complex class 1, strength for antigen presentation efficiency. Serre has a transformative constant between antigen presentation, antigen amounts and immune effectors, and Gong relates T cell recruitment rate to mutational burden and antigen strength. So to go a bit more into MHC class 1 and the dendritic cell presentation, they present antigens from different sources. MHC class 1 is responsible for presenting intracellular antigens, so such as from inside a corrupted cell, whereas DCs exhibit MHC class 2 pathways responsible for intercellular antigens, such as from the TME, which is crucial after the violent irradiation-induced cell death. Some of these models also include the downregulation of immune effectors as well as their upregulation. Gong, Kosinski and Valentinuzzi consider the immunosuppressive T cell interactions. Gong considers a probability that a T cell will be inactivated if it comes into contact with a tumour cell expressing the PD-L1 suppressive ligand. Valentinuzzi has a similar mechanism and also includes PD-1 expression in the TME, and Kosinski considers the probability of a T cell inactivation, but also the sensitivity of PD-L1 to the upregulation in response to the immune action and the presence of separate immunosuppressive cells. The Serre model's unnamed immune effectors do not undergo an explicit downregulatory effect. So in summary for the immune effectors, cytotoxic T cells are the key immune effectors involved in the anti-tumour response, and dendritic cells are believed to be crucial for antigen presentation after radiation-induced death. Therefore, a future immuno-RT model should incorporate both these immune system components. So next, we look at the method of radiotherapy incorporation into the immuno-RT models. So both Kosinski and Serre use a slight variation upon the linear quadratic model. The LQ model is considered an acceptable radiation cell kill model for doses of up to 10 gray. The Serre model incorporates a daily weight to its linear quadratic cell kill, meaning that cells die according to a probability distribution and not immediately after being irradiated. This means that there's a higher level of tumour antigen production, and it reduces the immunogenicity of the tumour because this is inversely proportional to the surface area of the tumour in the Serre model. The Kosinski model contains the only fractionated radiotherapy model that we have found. It builds upon the linear quadratic method, using the average number of double-strand breaks per cell and its relation to the alpha parameter of the tumour type to characterise radioactive cell kill. It considers RT damaged pre-apoptotic tumour cells that contribute to the tumour bulk before they are cleared. So in summary, for the radiotherapy component, a small sample size of models means that there is little in the way of comparison of radiation incorporation into immuno-RT models. And the Kosinski and Sayre models possess many similarities and both utilise the linear quadratic model, and the Kosinski equation for the effect of fractionated RT is worth further exploration and seems like an excellent part to include into a future model. So looking at accounting for inter-animal variation in the effects of therapies, IAV is one of the greatest issues for determining the optimal cancer therapies. The heterogeneous nature of cancers between patients makes it very difficult to determine whether an individual will respond to the treatment. Kosinski et al. Attempted to explain variations in animal response by varying the exponential growth parameter in their logistic tumour growth model. But they found that it did not explain IAV in the experimental data. However, as mentioned previously, this could be due to the poor experimental fit of their logistic model and not an issue with the variation type itself. But the Kosinski model found that variation in the tumour infiltration ability did provide good explanation for IAV. Gong found that increased antigen strength and greater mutational burden had a positive effect on treatment outcomes. So in summary for the IAV, we need to explore each of these variations to account for IAV in experimental outcomes. And though Kosinski et al. Did not have success with their exponential tumour growth parameter, that could be an issue with the tumour growth model itself, and so for a future model, it would be worth varying this in a Gompertz growth model. Next, the computational basis of the model. The Kosinski and Valentinuzzi models were made using Matlab with specialised toolboxes, and the Gong model was run in Windows and Linux operating systems and built in the freely available C++. The quantitative systems pharmacology toolbox used in the Kosinski model is freely available online. The Gong model is available in its entirety in the supplementary materials available online. The Matlab code for the Valentinuzzi model has kindly been provided by the lead author. And though it is not specified what was used to build the Sayre model, the equations are freely available in their paper. So the benefits of using Matlab are the multitude of specialised toolboxes that are readily available online. But it is a proprietary language and this always puts limitations. It can make it more difficult to collaborate with other authors or perhaps pay for the software in a non-student situation. The power of Matlab makes it an excellent potential for building a future immuno-RT model, but consideration should also be given to the non-proprietary languages such as Python and C++. So the importance of testing and training data is that it has to be correct in order to ensure the predictive ability of a model. Not all of the data sets used by the primary models recorded the specifics of their experiments. For example, only a single study used to train the Kosinski model specified the radiation regime used to obtain their immuno-RT results. Inconsistencies in radiotherapy dose rate, tumour cell lines, and immunotherapy clones may have an impact upon the validity of these outcomes. So consistency is required in testing and training data to ensure that the model actually offers insight into treatment efficacy. This is difficult to achieve with studies that have already been conducted, as they may not have mentioned the required parameters with the rigorousness required for model incorporation. As such, the best option is to design prospective studies based upon the outcomes of computational models, such as this one, so that this data can be used to train future models and ensure predictive ability. So now onto sensitive parameters and indications of treatment success. After considering the core aspects of each model, the next step was analysing the sensitivity analyses of each model or performing one if it was not there. The purpose of the sensitivity analysis is to determine which parameters have the most effect on model outcomes and therefore the most potential effect on treatment outcomes. Kosinski et al. And Valentinuzzi et al. Performed their own, so this study attempted to reconstruct the Sayre model in Python and use the say-lib sensitivity analysis package to perform the analysis. Sadly, this did not go so well. This was meant to replicate this diagram and did not. But as this was one of the first projects undertaken over the course of this project, it was only realised later that because of the high degree of free parameters in the Sayre model, that a sensitivity analysis would not actually unearth any useful information. and as such, it was considered merely a coding exercise, and further effort was expended on the more quantitative models. So, looking at the quantitative models, the most sensitive parameters were the intrinsic tumour growth rate, or the exponential parameter, in our logistic and Gompertz growth models. Valentinuzzi obtained their parameter through fits to experimental data, so it is a free parameter, and Kosinski obtained theirs through an experiment. Because there are so many factors that affect intrinsic growth rate, in fact, the study that Kosinski used showed how temperature had a huge effect on the tumour growth rate in mice, studies should be designed such that the tumour growth rate can be determined parallel with treatment efficacy experiments. Another sensitive parameter are T-cell related parameters. Valentinuzzi et al. And Kosinski found that T-cell infiltration related parameters were also quite sensitive. Kosinski contained additional parameters relating to T-cell interactions such as half-life and cell division cycles, and these were all highly sensitive and free, so this may contribute to model complexity without increasing prediction strength. Valentinuzzi et al. Found that the MHC class 1 expression and mutagenic burden, or the variability in the number of mutations, were also highly sensitive. So next, looking at the TIL penetration in specifics. The Kosinski model found that an increased degree of TIL penetration into tumours correlated with improved treatment outcomes. Experimental evidence indicates that the high presence of TILs can be indicative of surgical treatment success for more advanced cancers, and as immuno-RT therapies are used on refractory or late-stage cancers, the degree of T-cell penetration may have a profound effect on treatment success. The Valentinuzzi model found that MHC class 1 expression corresponded with better treatment outcomes as well. One study found that lower levels of MHC class 1 expression resulted in lower levels of cytotoxic T cells within the tumour, but that it could be improved through radiotherapy and may result in an improved anti-tumour response. An immuno-RT model may benefit from the consideration of MHC class 1 and the interlinked effects of radiotherapy. Gong and Valentinuzzi found that increased mutational burden resulted in better therapy outcomes. Positive correlation of mutational burden to treatment success has been indicated by multiple experimental studies. Radiation treatment results in increased genetic mutations, but these mutations may not be immunogenic and so not actually increase the immune response at all. Gong found also that increased antigen strength corresponded to better treatment outcomes, and the effect of mutational burden and antigen strength is worth further investigation, particularly when under the influence of radiotherapy. So in terms of scheduling of treatments, both Kosinski and Sayre found that coincident ICI and RT administrations resulted in optimal treatment outcomes. Experimental data has found close sequencing of radiotherapy and ICI resulted in increased abscopal effect post-treatment. So in conclusion, a future model should be constructed in Matlab, or it could be constructed in a non-proprietary software, but the benefits of Matlab and its many toolboxes do offer a very appealing advantage. Utilise bottom-up modelling methodologies, giving consideration to minimising the number of free parameters, with the goal of ultimately extending to a multi-scale model. Use a Gompertz growth model, as it is a suitable combination of simplistic and representative of experimental data. Considering the removal rate of dead tumour cells and how this will affect measured tumour bulk and immunogenicity. It should also use cytotoxic T cells as key immune effectors and incorporate immune downregulation in the form of T cell interactions with immune checkpoints. Consider both MHC class 1 and dendritic form of antigen presentation to account for both paths of presentation and incorporate the Kosinski model fractionated RT. Also key is further research into investigating inter-animal variation by modulating the Gompertz exponential parameter and TIL infiltration degree parameter in the future model. Investigate the impact of single nucleotide variations or mutational burden and antigen strength on model outcomes and timing of immuno-RT therapies. So the clinical impact is that these models can inform future quantitative experiments and then be used to determine individualised treatment regimens to optimise patient outcomes or determine if treatments are efficacious, based upon key biomarkers of success. So I would like to say a big thank you to both you guys.